Thank you for the invitation from Morten and I. Yes, in this session, the next 24 minutes, we will give you an insight in parasport. This is not a subject that is rarely seen on this congress, but now we at least have a chance to present some of the parasport and how the parasport had developed through a lot of years. So what we will discuss in this session is health complaint in parasport, but we will also see what is happening, what is parasport, why parasport, the history, and then of course also we'll talk about health complaints in parasport, and last, science in parasport. And then we have the pictures of us. That's we will move on because Camilla have already said that. Let's see if I can start this video. See, come on. Yeah. As you can see, he is moving through a lot of different phases. He have been into an accident, and in parasport, a lot of people are born with disabilities, but also a lot of people have had an accident in their life, and then they try to, or then they can use the sport to get more self-esteem again, and maybe be better also in rehabilitation. So parasport is more of being disabled. It's about rehabilitation, and it's about finding out who you are again, and it's also about socializing in society, so you can be a part of the world. And we actually have now I can't go to the next slide. We have like this. In Denmark, we have Daniel Jørgensen, who also had an accident. He was actually an elite gymnast once, and then he had an accident and lost some of his legs in a trampoline. But then he was unstoppable because he wants to keep on going. He wants to do something in sport still, and that's why he started to train and did a lot in athletics, in parasport, and now he is a gold medal in Paralympic. So there's a lot of reason for coming into parasport. That's why, because parasport is fun. Also, we have here, this is the former, he was the chairman of Parasport Denmark, Carl Wilhelm Nielsen. Now he retired. But when he was a boy, nobody in school, he was told that he couldn't play sport, and that was not very happy for him. So when he came home, then he planned games at home where he lived, and then all boys nearby, they were playing together with him, and he was trying to do different things so it would be fair game. So he was actually the one who started all this parasport in Denmark, tried to organize parasport. Now we have the chairman of Parasport Denmark now is John Pedersen. He is born with arms and legs that are short, but he is also a Paralympic and have won a lot of medals. So it's about keep on going, then you will have success. But then we have a little bit about the history also. Actually, parasport have been in the area for over 100 years. It started with deaf people because they have arm and legs normal, but they couldn't hear, and then it moved on. And then in the 40s, this man, Sir Ludwig Guttmann, he was the man behind the Paralympic Great Movement, because that was after Second World War, and with a number of injured soldiers, then he started to work with them because they needed re-education and rehabilitation, and that was he was doing. So he started to do sport with all the soldiers, and in the end, this meant so much to them. And then he introduced the sport to the Paralympic in London as a show of sport. So that's actually the beginning of the Paralympic. So he have meant a lot too. And now we have a small video again showing the story. Let's see if I can find out the story. Whoop. Whoop. And that tells a lot about.
In 1944, a Jewish doctor who was a refugee from Nazi Germany started a new spinal injuries unit at Stoke Mandeville Hospital. At the time, patients were only expected to live for 2 years, so the idea was to make their remaining days as comfortable as possible. Ludwig Guttmann had other ideas about their life expectancy and insisted on managing treatment his way. His approach was controversial to many, but Guttmann single-handedly revolutionized the care of the paralyzed. He got patients off sedation and turned in bed every 2 hours to prevent infections. Next, he insisted they got up and moved around by taking part in craft and sporting activities. One of Guttmann's most inspired ideas was to get wheelchair patients playing competitive sport as a way of improving fitness, boosting self-esteem and restoring personal dignity.
It changed my world out of all recognition, because it gave me so much more confidence. You know, I knew that I was equal to anybody. I don't know where I would have been without him.
On the same day as the opening of the 1948 London Olympic Games, Dr. Guttmann organised a team from the Star and Garter home to compete in an archery demonstration, and it had a lasting impact. The 14 men and 2 women who took part that day became the first Paralympians. Guttmann organised a similar event every year, and in each successive year, the Games got bigger and better. In 1952, the first international event was held when a small team from the Netherlands came to compete. From this date, Popper, as he was endearingly known, referred to the Games as the Olympics of the Disabled.
How important are games like these to paraplegics?
Very important, see, from both the physical and psychological point of view, but the most important is from the point of the social reintegration of the paralyzed into society.
The 1960 event is widely thought of as the first Paralympic Games, being held overseas for the first time, just after the Olympics in Rome.
400 paralyzed men and women took part, representing 24 countries.
From this point on, an annual event was held at Stoke Mandeville, and in each Olympic year, the Games moved, in the hope that they would be held in the Olympic city.
My first ever Paralympic Games was Tokyo, and I was lucky enough to come back with 2 gold medals, including the first ever track event.
The Paralympic movement continued to grow.
Papa Guttmann would have loved to have been here now.
Yeah. As you can hear, he have meant a lot to parasport. But there we have now here a short list about what year have been very important for parasport. And also you can see here in the 60s, the intellectual disabled also came through, because that was actually the Kennedy clan. Inez Kennedy, she's a sister to Jack and Bobby Kennedy. They had a sister who also had intellectual disabilities, and they started to do games for intellectual disabilities, and now it have also grown very big. So actually now Special Olympics is the biggest event in sports event in the whole world. Last year, 7,000 participants were joining games in Abu Dhabi. So that have been a huge developing. Then you also have in 1989 where International Paralympic Committee is founded in Düsseldorf. And that is a committee that makes sure that you have fair game and also look a lot about science in this area. So that is actually very good that we have that to make sure that it will be fair game all around the world. In Denmark, organizing parasport in Denmark has been a long journey also as in the rest of the world. In parasport, there is a lot of volunteers, and right now we are starting to be more and more professional, actually. Parasport Denmark, we have separated up into physical disabilities. There you have a mass participation sport, and you also have a elite part who are participate in the Paralympic. And then you have all the intellectual disabilities who are, some of them are doing Special Olympics and travel around in the world. But the new thing here is that the elite part is now having agreements with Team Denmark Able Sport. And that is actually the new thing in the history, that now we are moving towards the able sport. So now clubs have, in the future, more clubs will have disabled in able clubs, so they can work together and develop from there. Here we have some of the great experience from Denmark and Danish team, just to make a little bit commercial, that of course not all disabled come and get some medals, but you have to start somewhere, and it's about getting health and having fun together with other people. And that was the last thing here. I want to say that the elite part have now a cooperation with Team Denmark. So when we go to Tokyo, Olympic, Paralympic, they have a cooperation together. Yeah, Morten, do you continue?
Thank you. Well, I have to talk about the health complaints among parasports athletes. In brief, a lot of issues you can talk about, but in brief, what's the difference between parasport athletes and healthy athletes in sports? And there are a lot of differences. I'll just take it brief. First, the mental status. It is known that there are more mental issues in parasport athletes than in able sports athletes. It's both illness and, what do you call it, mental issues. You can imagine yourself with crippled arms and legs standing in a swim, wearing just your swimsuit, and you have to perform. You are a part of that sport with your crippled body, and you have to see yourself as an athlete. You perform differently as able sportsmen, and you look differently. You have to accept that. And that's a small part of the mental issue, and that's where the parasport can lift you back to so-called normal life. Physical deficits, of course you have amputations, and Jan will talk later about spinal cord injuries, cerebral palsy, deafness, blindness, etc., etc., etc. That's the difference. You have to cope with that as a doctor, as an athlete. The disabilities you have means a different load on your body. That means you see another pattern of injuries. You have physiological changes, circulation, sweat, water uptake, blood pressure, osteoporosis, etc., etc., etc. And then you have another issue. You have a disability, and that's why you have to use wheelchair. You have to use other devices to make you work in the sport, and you have an interaction between your body and the wheelchair, the prosthesis, etc. And that means you could have a problem with skin breakdown, misuse, overuse, etc. And then you have a bunch of other problems you have to solve. What to do with the ventilator when you're sitting in a wheelchair playing football? What about your urine bag when you're using a race runner, etc.? So you have a lot of different issues. As an example of the last physiological issue here, I have chosen to take the body temperature regulation. Doing sports, you have muscle activity, making your body warmer. Normally you want to have your body temperature about 37 degrees. When you cannot sweat because of your spinal cord injury, your nerves doesn't work properly, you cannot sweat, the vessels in your skin cannot dilate, you cannot cope with the heat. So you may overheat, but respiration makes your mouth dry, then you'll drink, but you cannot sweat, so you might overheat and overhydrate. That's just one of the issues. Other issues is osteoporosis. You don't feel if you are injured and have a fracture, you just have another sensation. You have to cope with that as a trainer, as a doctor. Classification is essential in parasports. Without it, the game will not be fair. There are a lot of classes in parasports because you have different issues, table tennis, running. So there are a lot of different classes. And you can imagine one of our top athletes will ask, why do you compete in parasport? You're just missing part of a hand. You can try yourself when you're going for a run or a swim. Try to run with your hand taped in gaffer tape or your hand just in the pocket and see how you perform running. You can try to take a ride on your bike with your best friend and then just steer with one hand. You can see how fast you can go there. Just an example of why classification is so important. Normally, you test by muscle strength over the affected joints, joint movements, and then you observe the athletes perform in sports. Maybe that will change, but that's another story. In other sports, you have, for example, in goalball, you're blinded, so you can participate in goalball, although you have a little sight back, but you're blinded, so everything is equal. All players are blinded. Yeah. What kind of complaints do we see in parasports? Of course, you see injuries here. Normally, of course, when you're doing sports, when you're active, you have a certain risk of injuries, but in parasports, your risk is higher. The International Paralympic Committee has done a great job doing surveys during the Paralympic Games, and you can see, compared to Olympic Games, there are more injuries during the Paralympic Games. Then you have the risk of overuse because you are not in balance. You have to put more load on, so to speak, the rest of your body, and you can have misuse injuries. As you saw in the video, maybe you didn't notice, but the runner, he was having a blade on his left leg, I think it was, and his right shoulder when he was running, he was just making a small push every time. Yeah, 2 minutes, yeah. He was making a small push forward with his right shoulder, and that means maybe he can have a misuse injury to the shoulder. Then you have a lot of illnesses related to the disabilities, especially the nerve affection, skin breakdown, as I talked about, osteoporosis, and then the mental issues. And you have to cope with heat and cold. And then, in 1.5 minutes, I'll talk about why science in parasports. I've just looked on PubMed, and I searched on sports medicine in able sports. You can see there's a huge incline in numbers of articles published, and a very fair, big number. And this is the parasport, disabled sports. Very low, very small incline. So this is a commercial. If you're going into science, parasport. What's the aim of the science? It is to modify sports and classification to fit the athlete and reduce injuries. You have to understand the athlete, the disability, the sport, and most of all, the interaction between these trees. And how do you do it? Science, back to the lab. And how do you do it? Find the problem, find the mechanism of injuries, how to introduce preventive measurements, and then go back and see if you have solved the problem. Jan will tell about spinal cord injuries later on in this session. I've heard him talk about it earlier, so that's why I call him Mr. Science of Scandinavia. You have to ask the right question, and that is very, very important. The right question, then you are nearly half done with your work. Collect data about the question, analyze. Did you get the answer? No, back again. So that's Jens, most of his work I have seen is about this. So 30 seconds too much, I think. So thank you for your attention, and get into parasport.
Ja, jamen det godt.
If you have some questions, you are very welcome to pose some questions to Rikke and Morten about this. Otherwise, we will go further to the next. No questions? I have one question to Morten. So Morten, which major obstacles do you see in bringing Parasport Denmark up to an international level in science?
Money. That's it. Well, we have a science policy in Parasport Denmark, and we have a cooperation with the university in Odense, and that's how to start. And we need funding because, well, it costs to do science. But we have started, and we have the policy how to get into science, but it will take years to get there. What we are trying to do is to get, as you saw, there's the number of papers published about parasports is very low. But it's our aim to get into the published papers and get it into so to speak, real life into training. So all the trainers, they know what's the new in science, and that's our way to do it. But most of it is on what they call a volunteer basis.
Do you see Team Denmark as a sponsor in the future for the parasport, because they sponsor the able-bodied?
Yes.
But I don't think they sponsor so much in the parasport.
I see it a lot as a very good cooperation. And they're getting into parasports. The Danish Sports Society, DIF, is now organizing the Paralympics for Parasport Denmark, and that's the first step. We have some fundings we can use to, so that the athletes can get used to the warmth and the humidity in Tokyo in August and September. And that project is sponsored by Team Denmark. So we can have our para-athletes into Team Denmark projects on the same level as able athletes. So it is, for me to see, it's going the right way.
Okay, yeah. Slowly.
Slowly but steady.
Yeah. You have one question?
As research questions, what is the first question you want to answer?
Oh, there are a lot of questions. Maybe Jan, can you help me on that one? But there are a lot of, but at first, how many injuries do you see in parasport? What kind of injuries? How does it keep athletes from sports? And you can keep on asking, but you have to, if you ask the question, well, I don't know why they don't come for the training today. That's a question you cannot answer, but you have to be much more specific. So you have to think about the question. So what Jan has been doing is to collect data about illness and injuries among the Swedish athletes. And then you have a huge pile of data, and then you have to analyze, as I wrote up there, and then you got the answers. What is happening to the athletics in parasport when they get injured? That could be one question. And then you have the solution, collecting data. That could be, is my prosthesis good enough for riding a bike on a high level? Could it be more aerodynamic? That's another question.
It could also be recruitment, yeah, about how do you find all these people who are just sitting in a room, not doing anything but seeing TV and maybe have a disabilities. How could you motivate them to start sport, to get healthy, more healthy? That the humanist side of it also, the psychological side also, could be very interesting.
Okay, I think we will stop for now in this very interesting discussion and move on to our next speaker, who is Camilla Marie Larsen, who has a professional background as a physiotherapist, a Master of Science, and a PhD in health science. Now Camilla is a postdoc and teaching assistant professor with affiliations with the research unit of musculoskeletal function and physiotherapy at University of Southern Denmark. And she's also working at the Health Science Research Center at University College in Odense. For the past years, her research focus has been on shoulder pain in a cohort of Danish people with spinal cord injuries, both on those performing and not performing physical activity. So to do research within this area in Denmark, she has also translated and validated 2 international questionnaires to Danish. Danish is a small country, you know, on shoulder pain and physical activity. She is performing a systematic review on how to prevent and treat shoulder pain among spinal cord injured. Camilla will present her cohort study on spinal cord injured in Denmark, the amount of shoulder pain, and whether this is influenced by the level of physical activity. So please, Camilla, the floor is yours.
Thank you for the introduction, Birgit. Can you hear me? Or, yeah, is that fine? Okay. Well, also thank you for the opportunity to present here today. The shoulder is a common site of complaints among individuals with spinal cord injury. And in this relation, there has been reported a wide range of prevalences. And the shoulder pain is anticipated to be up to almost 3 times higher than in the general population. And shoulder complaints have been reported both in relation to wheelchair use, but also in relation to use of other types of assistive devices for mobility. A higher prevalence and intensity of shoulder symptoms, shoulder pain, has been found in tetraplegic individuals, those with a high level of injury, compared to individuals with injuries at lower levels. And although shoulder pain has a multifactorial etiology, it is believed to be primarily a result of the increased biomechanical load imposed on the upper limbs. Now, the number of people in Denmark living with a spinal cord injury is around 3,000 people, with an annual incidence of around 160 cases. The presence of shoulder symptoms may limit function and independence, and due to inactivity, these aspects can lead to increased health risks and increased quality of life. As you've already heard, in recent years, the popularity of disabled sports and physical activity has grown extensively. And typical types of physical activity for individuals with a spinal cord injury include wheelchair sports, for example, rugby, basket, sitting aerobics, water aerobics, cycling, strength training, and walking. And as for the able-bodied population, regular physical activity can contribute to improve fitness, cardiometabolic health, as well as personal and social well-being. However, sports participation and participation in physical activities can also add to the daily shoulder load, inducing an increased risk of shoulder symptoms. The association between physical activity and shoulder symptoms is not clear. The few studies that actually exist in this area point in different directions. Some point towards physical activity as a possible preventive factor, and others point towards physical activity as a risk factor. We've also heard that several times today, actually, in other areas. But both the large variation in prevalence estimates of shoulder symptoms and the uncertainty of risk or preventive factors may be due to different methods, outcomes, populations, and sample sizes. Often sample sizes in this aspect are rather small. Therefore, the aims were to describe the prevalence of shoulder symptoms and the amount of leisure time physical activity in individuals living with chronic spinal cord injury in Denmark. An amount of activity is measured in minutes last week. And also to investigate the association between amounts of leisure time physical activity and shoulder symptoms. And to explore these aspects, we initiated the Danish Spinal Cord Injury Shoulder Study. The inclusion criteria were participants with a spinal cord injury following traumatic or non-traumatic lesions within the last 2 years. For at least 2 years, that was what I meant. They should be adults and registered in the electronic databases at either 2 hospital clinics or 1 rehabilitation clinic. They further should be able to understand and speak spoken and written Danish. We also listed up some exclusion criteria, as you can see here. From the standardized Nordic questionnaire, we asked about shoulder symptoms for the past 3 months. And if answered affirmatively, they were asked about the number of days having symptoms within the past 3 months. And also if symptoms had prevented them from their usual activities. And for the analysis, the number of days were merged into either 30 days or below, or more than 30 days of symptoms. We assessed the amount of minutes of physical activity the past week using the Leisure Time Physical Activity Questionnaire for people with spinal cord injury. And by 3 questions, we asked about minutes of mild, moderate, and heavy intensity activity the last 7 days. The total amount of weekly minutes of activity was divided in tertiles in 3 groups, where the lowest 25% of the data points defined the group with low amount of activity, the middle 50% of the data points defined the mid group, and the highest 25% of the data points defined the group with the highest amount of physical activity. A cover letter containing information about the study and a personal code for a web-based questionnaire was posted to all possible responders. And by filling out the questionnaire, the participants gave their informed consent to participate in the study. In the third reminder, also a paper-based questionnaire along with a pre-stamped envelope was included. Now moving on to the results. The final sample comprised of 1,517 individuals, resulting in a response rate of 62%. And the mean age of all participants was around 56 years, and men comprised the majority. Mean time since injury was about 17 years. Less than half had sustained a cervical injury, and a traumatic injury constituted more than half of the participants. And less than 1/4 of the participants were classified with a complete injury. Around 80% used some form of assistive device. And the participants' use of assistive devices are further visualized in this figure. Use of manual wheelchair for mobility, and for some in combination with other assistive devices or a power wheelchair, was the type of assistive device most frequently reported, followed by use of assistive devices for walking. So these groups are the 2 major ones. Now looking at what did they report about shoulder symptoms, 63% actually reported shoulder symptoms in one or both shoulders for the past 3 months. And of these 63%, more than half reported shoulder symptoms for 30 days up to every day. And furthermore, symptoms often prevented them in performing their usual activities. Now, if we then look at the amount of leisure time physical activity, this table here presents the median values and interquartile range of the total score of minutes per week of physical activity, and the median values of the total score in these tertile, in these groups of low, middle, and high amounts. As seen from these results, the median of the total score was 336 minutes, corresponding to around 5.5 hours a week. And the median values of the tertiles goes from 4 minutes a week in the group with the lowest amount and up to 1,260 minutes in the group with the highest amounts, corresponding to 3 hours a day. And the total amount in minutes of leisure time physical activity found in this study are somewhat higher if we compare our population with a population from the States, but more similar if we compare our results to a population here in Europe. So there are a huge range in the amount of activity. Now this table shows the results on this association we looked at between the amounts of self-reported physical activity and having shoulder symptoms for the last 3 months. Amounts of activity are presented here in the 3 groups: low, middle, and high, and as I just showed you before. And results are presented here in odds ratios, where a value above 1 indicates an increased likelihood of symptoms, and a value below 1 indicates a reduced likelihood. So the group here with the lowest amount is the reference group. And from these results, when we look at all the numbers, we can see that there is no association. We further assessed the likelihood of having symptoms for 30 days or more. And also if being prevented from usual activities due to symptoms was a factor. Again, we don't see any clear associations, although we did see some indications of a reduced likelihood of having symptoms for the last 30 days if being physically active. Now, our results are in line with a study from Switzerland, including a similar population, also of similar size. And they also found no association between shoulder pain and frequency of sports participation. Now, this was the broad group. We also did a sensitivity analysis, just looking at the individuals using a manual wheelchair. Again, we think about the load as a factor. And we more or less get the same results if we look at the numbers. Although the reduced likelihood of having symptoms for more than 30 days when being physically active, which is the numbers there in the middle, they are not indicated here. But instead, we see indications of an increased likelihood of reporting symptoms within the last 3 months in the group with the highest amount of activity compared with the group with low amount. That is the red box over at the left. Also, these results are in line with results from an unpublished Dutch study in around 300 individuals, reporting that upper extremity pain appears not to be related to exercise capacity or physical activity in wheelchair users. One cohort study exists in this area. It was conducted by Sarah Mulroy and her colleagues, including around 200 individuals, and they found no association between objectively measured physical activity and shoulder pain. But they did indicate that strength, muscle strength, may be a possible risk factor instead. Now, due to the nature of its cross-sectional design, we cannot determine any cause and effect relationship. But we did include internationally recognized data sets and questionnaires. However, self-reported instruments are reliant upon the accuracy of the participants' memory and recall, and therefore may be subject to reporting bias. But we did what we could in the design here, but there is always this aspect. We most likely think we have addressed the majority of the total Danish population of spinal cord injured individuals. And we also find our demographic results representative. And furthermore, some of our previous results have actually shown that that the non-participants and the participants are largely similar. Sorry. We could also assess that response rate of the 62%. Is that low or what? But although this is somewhat higher than previously reported within cross-sectional studies of similar sizes, where the response rates have been below and at 44%, 41% up to 49%. So this is actually higher. Now, to conclude on these results, we found a high prevalence of self-reported shoulder symptoms and also a very large variation in the amount of self-reported leisure time physical activity. Actually, a large group of these individuals were not physically active. No clear and consistent associations were found between amounts of leisure time physical activity and shoulder symptoms. Now, the amount or the load of moderate and heavy physical activity should be further assessed, and that is also a focus of future analysis, because that could actually be relevant to look into. And also other factors like activity type and muscle strength could be of importance and need further investigation. In our sensitivity analysis, we found similar results for the group of manual wheelchair users only. So I would like to say thank you for your attention and to all collaborators, co-authors and funding agencies.
Thank you very much, Camilla. Are there any questions?
We were at the Vista conference in Amsterdam last fall, and there was a similar talk about shoulder problems in parasports, and the conclusion was that the risk of having pain from the shoulder were half that of normal athletes, but what do I call it? But you have more higher risk of having injured shoulders, but the pain were not so likely to be to be felt.
So you are talking about overuse and traumatic pain.
I can't remember what it was. I think it was all in one. As a conclusion in parasport, you have a double risk of having an injury to the shoulder, but just half the complaints.
Yeah, so it's
Something
again,
like
it's
that.
difficult to, it's different if you report symptoms or if you have an injury. Yeah, because here I didn't assess any types of injury, I just assessed the complaints.
Yeah.
But here we can see that that the complaints are much higher than compared to the normal population. But again, what is the consequences of these symptoms? I cannot say right now, but I can say that they complain about it, and for some it's a high intensity. But I totally agree. It's different if you report pain or if you have an injury. They are not always related.
No. But that means that's a new aim to have to see how can we protect shoulders in spinal cord injured athletes.
Yeah, and especially the prevention aspect is really underlooked. It is underlooked within the sports setting and the rehabilitation setting also. Now we have looked very carefully into the literature in all this, in this whole area, and very limited studies, and especially studies of high quality, very few. So there is a huge gap in the literature. Also in respect to treatment, but especially in prevention. Both in sports setting and in rehabilitation setting. Yeah.
I have a question. You showed that the duration of physical activity does not influence the risk of shoulder symptoms.
Or amount.
Yeah, duration or amount. You counted all the minutes and merged the different levels, the different intensity levels.
Yeah.
So could you, from your data, say anything about which intensity level of physical activity is harmful or beneficial for the shoulder?
No, this is a total score of both mild, moderate and heavy intensities. But also in this population, repetitive activity or movement of mild intensities has been pointed at as an issue, the repetitive factor. So you cannot always say that it has to be moderate or heavy. But of course, it would be very interesting, and what is also the focus of next step or next studies, to look more into the moderate and the heavy load. Also, if you follow guidelines, if you follow or not follow the guidelines specifically for this group. But you're quite right. The mild activity are included in this aspect also.
And there are some international recommendations for physical activity, which we know that Jan Lexell will talk about. Can you, from your cohort of people with spinal cord injuries, can you say how many of these people are fulfilling the recommendations, official international recommendations for physical activity?
I can for some part of it, because the recommendations are specific in different parts, relating both to strength and also cardiovascular activity. But if you are engaged, whether or not you are engaged in 90 minutes per week in moderate and heavy intensity activities, around 56% are fulfilling these guidelines, and around 44% are not fulfilling these guidelines of 90 minutes per week of moderate to heavy intensity activity. So it is more than in the able-bodied population, and again, a lot of these that are not fulfilling the criteria are not active at all.
Is that the old people that are not active?
I don't have that specific answer right now. But there are a lot of people that are very, very limited active. Yeah. Mm. Okay?
Yeah. Okay. Thank you very much. Camilla?
Yeah. Now, while Jan is setting up his presentation, I would also very much like to welcome our last speaker, Professor Jan Lexell, a professor in rehabilitation medicine from the Department of Health Sciences at Lund University in Sweden, and a senior consultant in neurological rehabilitation at Skåne University Hospital, also in Lund. He's also medical consultant and sports concussion expert at Hermelinen Sports Concussion Center in Luleå, northern Sweden, a national center of excellence for athletes with head trauma. He's head of the research group for rehabilitation medicine at Institute for Health Science at Lund University, where his research group studies the consequences of a neurological disability in a lifelong perspective. His research includes people with spinal cord injury, traumatic brain injury, stroke, and other neurological disorders. He's standing member of the medical committee in the International Paralympic Committee and board member of the Swedish Research Council for Sports Science. One of his research areas is related to physical activity for people with disabilities, adapted sports, and Paralympic sports medicine, in particular injuries and illnesses in parasport. And in this respect, he is participating in developing the guidelines on physical activity for individuals with spinal cord injury. Again, a warm welcome, and the floor is yours, Jan.
Thank you very much for the introduction, and also for the invitation to come and talk here. Last time I was here, well, the first time I should say I was here was 1996, so this over 20 years ago. That was when I was involved in muscle research and doing training studies of older people. I've sort of taken my interest in sports medicine, which started when I entered medical school, and brought that into the area of rehabilitation medicine, which is the ideal combination of sports medicine and people with disabilities. And it's natural to work with Paralympic sports in that respect. But also an area which is now named adapted sports, and there are some other definitions or terms being used here. My presentation will focus more on this sort of the health side of people with spinal cord injuries, and taking it a little bit into the area of also sports. I think we all agree about the benefits of physical activity and training for people in general. And the term exercise is medicine, which has been coined and used over and over again, is now also being brought into life of us as clinicians, so that we more and more focus on how to promote health in people. What we know, and especially from the area of people with disabilities, and you heard that in the previous presentation, that people with disabilities are much less physically active and often do not meet recommendations. So there's generally a need to promote physical activity and sports in this segment. And we also need much more knowledge about why and how to do that. And on a broader level, which you also heard from the first presentations, we need to engage in the development in society, healthcare, and among clinicians and researchers about the benefits of physical activity and sports for people with disabilities. What's interesting, you also heard the reference to Ludwig Guttmann. You may think that the area of sports and physical activity for people with disabilities is new, but it really started almost 80 years ago. And when Ludwig Guttmann established the National Spinal Injuries Center at Stoke Mandeville, he used sport and physical activity very much as part of the rehabilitation program. This is 80 years ago, and we still, you can see the number of people being interested in a conference with 500 people interested in sports medicine turning up, talking about what is the cutting edge of health promotion in terms of society. We have a long way to go still to promote sports and physical activity for this group of people. In my presentation, I'm going to talk very briefly about spinal cord injuries, then move on to physical activity and exercise, definitions and so on, and then talk about the guidelines that I've been involved in, the international development of the guidelines and how we transferred those guidelines and expanded them into the Swedish society, and then finishing off a little bit with organized sport, which is basically taking physical activity into a specific context. You're not just doing physical activity, but you're doing it together with others, where sport is one for a very good way of performing physical activity. And we also know from research about the barriers and facilitators to being engaged in organized sports. We heard now a little bit about spinal cord injury. Just to summarize the field, you know that is a damage leading to a lot of health issues. This is a large group, somewhere around 250,000 up to 500,000 people being affected worldwide every year. In Sweden, we have about 300 new cases, which would amount to about half of that in Denmark. You heard from Camilla that they approached about 2,500 people with spinal cord injury, which is again half of what the 5,000 we have in Sweden. It's a variety of consequences when you injure your spinal cord, anything from complete to non-complete. You also have non-traumatic injuries, and you then have anything from a severe disability in the very high level injuries to full restoration, actually. People who have just minimal consequences and minimal symptoms of a spinal cord injury. Now, moving then into the field of physical activity, there's some very basics. You all know this, that physical activity is defined as any movement that requires energy. That's basically everything we do in their daily life. Even when you lay down, you consume some energy, but it's almost minimal. What we talk about, and you heard that from Camilla's presentation also, when it comes to people with disability, we're talking about leisure time physical activity. And we both refer to the questionnaire and the instrument used to collect data from our Canadian colleague Kathleen Martin-Guinness. Now, leisure time physical activity includes any activity that is performed during free time, which is distinguished from the activities of daily living. So basically, when you're just dressing and grooming and bathing, you're consuming some energy. But on top of that, you're doing also some activities, and that's what included in the questionnaire. And this then physical activity can be either aerobic or muscle strengthening. When it comes to exercise, that is what is defined as some planned, structured, repetitive movement designed specifically to improve or maintain fitness. Again, aerobic and strengthening. It often involves a change of location, a change of clothing, and all that. And as you will see later on in the barriers and facilitators, these are some of the very basic barriers to people with disabilities. You don't change location that easily. Transport is one of the big issues to actually be involved in physical activity and sports. What's interesting during the past, let's say, 20, 25 years is that we've had a paradigm shift from fitness very much to health. And today, physical activity is being promoted not to improve the fitness primarily, but to improve health, and thereby reduce the risk of chronic diseases, prevent mortality, and maintain and improve physical and also mental capacity. And that is now being including any type of physical activity as being beneficial to you. In this regard, we can then take that across to general recommendations, and I will talk also about the recommendations that applies to people with specifically with spinal cord injury. The general recommendations come from the WHO. And you know that adult people from age 18 and onwards should be recommended to be physically active 150 minutes per week at moderate intensity or 75 at high intensity. And then combine that with muscle strengthening activities. Generally, the recommendations apply also to older people, which are also supposed to do some balance training. And what's interesting also in the WHO recommendations is that people should avoid sitting. And we have, and so how do you do that when you're in a wheelchair? Well, we have people doing sort of promoting the idea of avoiding sitting. Sitting is the new smoking, as we have some fundamentalists in Sweden. And I always approach them and say, so what do you recommend me to tell my clients with a spinal cord injury who's sitting in a wheelchair all day? And they look at me quite blunt, and I say, you cannot apply exactly the same recommendations from the general population across to the spinal cord injured people. And that is why there's been a large development worldwide, and in particular by colleagues in Canada, Professor Kathleen Martin-Guinness, who's now in British Columbia. She started already over 10 years ago working on the development of international guidelines for people with spinal cord injury with regard to exercise. That was then updated just 2 years ago, and I was involved in the work of updating the guidelines. And this slide summarizes some of these aspects, and we'll come back to this, how the development of guidelines took part. And this is the actual guidelines we will come back to. And here are some references. And if you want to, you can actually access a lot of information from a specific website called www.sci-guidelines.eu. And the guidelines are now being translated into a number of languages. The original ones that was developed, say, 2011, was translated into 16 languages. We're not quite approaching that yet, but we can see a steady growth in the number of guidelines. Well, taking now this is what we call an infographics, which was published in British Journal of Sports Medicine a bit over a year ago. It all started with a systematic review, and which came down to 189 studies of the effect of exercise on fitness, cardiometabolic health, and or bone health among adults with spinal cord injury. That in itself led to several international panel meetings when we were discussing how to transfer the scientific knowledge into specific guidelines. And that boiled down to the guidelines, which are now being promoted across the world. And it says that in terms of fitness, for cardiorespiratory fitness and muscle strength, adults with SCI should engage in at least 20 minutes of moderate to vigorous intensity of aerobic exercise twice a week. And then the same amount of twice a week of strength training with 3 sets of exercises. For cardiometabolic health, which was new to the guidelines, the recommendation is 30 minutes of moderate to vigorous intensity 3 times a week. Cardiometabolic health relates then to, for example, body mass index, glucose intolerance, cardiac health, and so on. And this is the new part where we say that this is the amount taken to actually reach the benefits in terms of both fitness and cardiometabolic health. When I meet my patients, many of them are quite astounded, saying, so it doesn't take more to actually become fit and healthy with regard to having a spinal cord injury? Well, in that case, I might actually start, they say, because many are very, very inactive. Now, this is the part which is moving on right now across, in particular in Canada, where there is now trying to promote the use of the guidelines across society. We have done a similar thing in Sweden. We have something called FYSS. FYSS in English is physical activity in the prevention and treatment of disease. This is like an encyclopedia of guidelines, knowledge and guidelines about physical activity in terms of number of diseases. There are 53 chapters. And what we've done for spinal cord injury and a number of other diseases is to actually grade the scientific evidence from anything from strong down to insufficient. And we did an update. The first one came 2017. We've now done an update and translation into English because the book is now being spread across Europe as a multi-country collaboration. And again, we see that aerobic fitness, muscle strength, body composition, and cardiometabolic health, there is moderately strong scientific evidence, which is interesting with regard to comparing that to any other treatment where you rarely reach such high level. Often you end up with just limited evidence or or insufficient scientific evidence. We also included pain, depression, and quality of life in our search and literature search and grading. We found slightly lower, but still some evidence that it affects pain, depression, and quality of life. And that, together with the international guidelines translated into the recommended physical activity in spinal cord injury, you can see that is very much the same as in the international one. We also say that the benefit of physical activity for people with chronic SCI, that is 1 year or ahead, 1 year post-injury, clearly outweighs any risk as long as you do it in a reasonably normal way. What we also say, and based on the literature, is that it should be you should carefully monitor health issues like autonomic dysreflexia, pressure sore, spasticity, etc., which means that the initiation of physical activity for people should to some extent be supervised by someone with knowledge of this group of people with disabilities and also tailored individually. Examples of, because someone say that, well, how do you actually train when you're in a wheelchair? Well, actually wheeling the wheelchair in itself is a physical activity. And you know, those in Denmark, you're fond of cycling. you have, so you can put your bike on a little stand, and you have the wheels, and you can do the same with the wheelchair. So you can actually sit in your wheelchair at home and propel the wheelchair without actually moving. Arm cycling is another one, and there are also stepping machines that you can use. Now, all this relates to physical activity per se. You're doing some kind of activity, and that is how you would see the sort of the health benefits of activities. But if you go back to what Ludwig Guttmann said, that he promoted sports as a way of being physically active. And a few years ago, I had a student who wanted to do a summer project, and we decided that, well, let's see what does the literature say in terms of science with regard to the beneficial effects of being engaged in organized sports. So this summarizes what at that time was known about in terms of activity, participation and quality of life in people with specifically neurological disabilities who participated in organized sports. We also looked into barriers and facilitators. I'm going to just quickly summarize that as well. What we found at that time, because that's what you all say, sport is good for you, sport is good for people with disabilities, but we found surprisingly few studies in terms of science. And which was timely for this presentation, that most of them were actually on adults with spinal cord injuries. So spinal cord injuries have for many decades been sort of a model for looking into physical activity and sports for people with disabilities. There were few studies on children and adolescents. Basically, there is a lack of definition. So we're into a gray zone. What do we actually mean by sports and physical activity? And many of the studies didn't quite distinguish between exercise in general and organized sports. I'm a strong believer that sport is a way of getting people motivated to be physically active. So when I come to the summary, I will show that this is perhaps the way we should go in terms of developing health promotion for people with disabilities. What we found in general was that in children and adolescents, there were, through sports, improved companionship, the sense of achievement, and heightened self-esteem. In terms of people with SCI specifically, there were improved self-confidence, self-esteem, quality of life, and performance of daily activities. Those were not covered by the general guidelines because the guidelines specifically looked at the fitness. So this is another benefit from being involved in organized sports. You perform better in terms of your dressing, clothing, etc., back home, and you feel mentally better. What's also interesting was that sport has shown in one study to have an effect on employment and community reintegration, exactly what Ludwig Guttmann proposed 80 years ago. This is one study looking at 48 participants with SCI. This comes from 2001, so there's studies dating back quite a number of years, looking into athletes and non-athletes with spinal cord injury. And they found significantly higher score in the athlete group in terms of physical independence, mobility, occupation, and social integration. Not surprisingly, but you need to prove it through science. This one, which is from 2013 by Cherie Blauet in Boston, who's also part of the IPC medical committee, herself a spinal cord injured person. And they looked into veterans with spinal cord injury and found that if veterans were participating in sports, they had a higher chance of being actually employed. Well, you can look at the other way and say, well, if you're employed, you engage in sports. But the interesting thing is that employment is actually a barrier to being engaged in sports because you don't have the time to be involved in sports. So generally what it says is that through sports, you develop sort of perhaps a mental and a physical strength, which makes you more employable, which is also interesting. When it comes to barriers and facilitators, this is something that people are still looking into, and I would say we don't need more studies of what barriers and facilitators there are. We need now studies, and answer to you, Hilde, about what science should we go into. That is, how can we reduce the barriers and promote the facilitators to get people more physically active? Because we know already what the barriers are. Dependency on others and lack of sports facilities. Again, if you don't have that, if you depend on others, you're not getting into sports. And also, which is interesting, some people have a negative self-perception. They have lack of time. But also all the health benefits, that is the facilitator. So if you promote sports through that, they will become engaged. And you can see the importance of the society and educated staff to deal with this. Financial constraints, lack of information, the cost of equipment, there are a number of barriers which we possibly could reduce to get people involved in sports. And this is where I think we need to move in terms of developing society, and then actually make some science out of that. So finally, as I pointed out, there is a continuum going from rehabilitation all the way up to Paralympic sports. What we need to have is knowledge of the importance of this for people with disabilities, understanding the role of organized sports, insight into barriers and facilitators, and that way we may be able to get people more engaged or involved in it. We also need to work towards a more inclusive society, and thereby develop and test new models to increase participation. I would say generally, and I hope you agree with me, that sports participation is a very effective complement to traditional rehab. We need to organize sports differently to increase facilitators and reduce barriers, so that we don't just look at the elite segment, the Paralympic, but also sports in general, and in that way improve life for people with disabilities. And myself, I believe that if you have a combination of interest in this and being a rehabilitation medicine specialist, you are particularly well suited. But anyone being involved in healthcare, interested in this, could develop the same skills.